One of the relationships I've gotten to have over the last several years on a national scale is Brock, our next speaker from the National Rural Health Association. He's a rural fellow, grew up on a farm in Kansas. His family still operates the farm. He started out as a respiratory therapist in the healthcare world, and he spent approximately 21 years being a CEO of small rural hospitals. I know in West Virginia and Mississippi for sure, so he knows of what he speaks. And the last thing I would say is he is a walking billboard for not smoking, having a vegetarian diet, routine exercise, and I've never seen him mad or honked off. The dude never ages. I've known him for 12 years and he looks the same, which is a good thing. Brock Slabach.
Well, thank you very much for that. Don introduced me several years ago when I was here, and he said I still had hair. And it was after that I started losing more of it. So I blame Don now when I look in the mirror and I see it thinning out a little bit more. Yeah, well, maybe so. I'll start that one here in a minute. Thank you, Don, for that introduction. And thanks, everyone, for the invitation to come back to Indianapolis. I have become quite like clockwork. When it's January, it's Indianapolis. So it's always a pleasure to be here, to spend time with all of you and to learn more about the problems that you all face. I will have to say that this is an interesting time to be involved in rural health. It's like the old author said, it's the best of times and the worst of times. So I'm going to talk about a lot of both today. So I hope mostly that when we're finished that you'll be able to leave here feeling hopeful and inspired about the work that you all are doing and why it's so important to the communities that you serve. I want to thank Don and Tina and others who've organized this meeting today, and the roster of folks. I was always able to listen to Dr. Adams speak prior to my presentation historically, and I've wondered how you were going to survive in Indiana without Dr. Adams here. And now I can see that you're doing quite well, because Dr. Box is just simply outstanding. And you all are blessed to have her as your public health officer in this state, to have such a grasp of the issues, to articulate a full range of what's going on in public health in this state, and being able to influence policy and actually mention rural and break out her data. I was really excited to see the data that she presented that had a rural breakout of the information that she presented. Well, I will say that I've been very pleased with the gracious responses about the Chiefs' loss Saturday night to the Patriots. This is only after, and it was especially gracious since the Chiefs beat the Colts a couple of weeks ago. But I can say that we're all kind of in the same sad place today. But anyway, I hope that the teams that are going to play will see a good game at the Super Bowl in a couple of weeks. Speaking of the Super Bowl, this is on the eve of our Policy Institute, so that'll be in 2 weeks in Washington, D.C., and so I look forward to seeing a lot of you over in Washington. As you know, your association, the National Rural Health Association, is dedicated to improving the lives of the 62 approximate millions of people that live in rural communities all over the United States. NRHA is nonprofit, and we're nonpartisan, so we don't have a particular side on an issue except that which is particularly rural and how we can help you in the work that you do in your communities. Here's a distribution of our membership, and it's always important for me to thank every single one of you here that are members of our association at the national level, including those that are members here in Indiana. Thank you for that as well. This is really the collective voice of your efforts at the national level to influence policy. And our tagline is making your voice louder, and this is exactly what I'm here to help do today. To influence, to help you and be inspired, to talk to your congressional representatives about the things that are important to your communities. Speaking of the Policy Institute, that'll be February 5 to 7 over in Washington. But I do want to focus down the road a little bit on our annual conference in May with the Rural Hospital Innovation Summit in Atlanta. And we're going to be in downtown Atlanta, so please make an effort to come over there. in May. I promise it'll be thought out by then, especially in Atlanta. The Rural Health Clinic Critical Access Hospital Conference will be in Kansas City later in this year in September. And then for the first time this year, I will make a special note. The NRHA, along with the University of New Mexico Health Science Center, will be sponsoring the World Rural Health Conference in Albuquerque in October of this year. I had the pleasure, the distinct privilege of going to New Delhi, India in April, where the 2018 conference was held. And I can tell you that it was an extremely inspirational and a very, very informative conference for me to attend. I was overwhelmed with the sense that sitting around the table with practitioners and professionals from places like Nepal and India and Bangladesh, I would find more in common with them than I do when I go to meetings here in this country and sit with my urban counterparts. The problems that we face with workforce, with poverty, with vulnerable populations is just really amazing in terms of the overlap. And really to find out that there is a lot of innovation that's going on around the world that could be very useful to us in our country in terms of understanding how rural populations can take advantage of that. So that's in Albuquerque in New Mexico. I will tell you that we're starting on the ending weekend of the International Balloon Festival. So if you've ever had on your bucket list to come to the Balloon Festival in Albuquerque, that would be a good time to do it. I do want to focus on the successes here in Indiana and thank the hospitals that have been named one of our top 20 hospitals over the years. Margaret Mary Health in Batesville in 2016 was a top critical access hospital. And then we've had two community hospitals here in the state of Indiana, rural community hospitals, achieve top 20 overall status. Those are Major Health Partners in Shelbyville, Indiana, and then Memorial Hospital and Healthcare Center in Jasper. Those two hospitals, both in 2017 and in 2018, achieved the top 20 Rural Community Hospital Award, and certainly congratulations to them. And then in 2016, Parkview Huntington Hospital in Huntington, Indiana, won that 2016 award. We will be issuing in 2019 the awards for the rural community hospitals at the Atlanta meeting in May of this year, and then obviously the critical access hospitals in October. My colleague that's helping to plan the conference in Albuquerque came up with this quote, which I'm happily going around and sharing with everyone because I think it really is appropriate when we start a conversation about policy. We, the willing, led by the unknowing, have been doing so much with so little for so long now that we are now qualified to do anything with nothing. I think if that doesn't describe the rural spirit, I think that's in a nutshell. I could actually stop after that comment because I think that really the credit all goes to you in this room. As Don said, I served a long time in a rural hospital, grew up in a farm in Kansas, and I can tell you that the challenges are certainly not getting easier, and we have a lot of work to do together, and sometimes feeling this way, hopefully, is not always, but it is something that we can all resonate with. We celebrated the birthday of Martin Luther King yesterday, actually, the holiday. And I think that one of the things that Dr. King really spoke to me about in terms of his life and his work was that of service. And a couple of quotes I picked out when preparing this: everybody can be great because anybody can serve. You don't have to have a college degree to serve. You don't have to make your subject and verb agree to serve. You only need a heart full of grace and a soul generated by love. And then he went on to say, we all may come on different ships, but we're in the same boat now. And I think that this is the spirit of rural, and I think that Dr. King is looking down on us today, hoping that we all understand the words that he shared so long ago and the inspiration that he provided to us. And so I wanted to just give that that note here today before we start today's presentation. So today's agenda is talking a little bit about what's going on in Washington. I say a little bit because, to Don's point, my blood does start to boil a little bit when I talk about the political situation that we're in, so we'll move past that pretty quickly. rural challenges and opportunities, and then end with some of the regulatory and legislative policies that we're tracking and that may be important to you here today. So I call this the Shutdown Showdown. We are now in the midst of going on almost 32 days, I think, in a shutdown of our federal government. And this is the direct results of the divisions that we have in our country that seem to be intractable. For the National Rural Health Association, our division is that around the rural, so we're rural advocates here in this room. We don't have any particular allegiance to Republicans or Democrats, only what is good for rural and only what is good for our providers divide. And so we're interested in good ideas regardless of where they come from, whether it's Republican, Democrat, or otherwise. So in the Senate, we had an election last November. It was a historic election in many ways. There were, at the end of the counting, 53 Republicans. We increased the size of the Republican majority in the Senate by 1. And then the Democrats now hold 47 seats. Two senators in the Democratic caucus are basically independents, but they caucus with the Democrats. That's Bernie Sanders from Vermont and Angus King from Maine. So those two caucus with the Democrats, making 47. So you can see here in this map, and why I like this map and I share it in my presentations, is you can see the relationship between red and rural. So this is an important correlation I want to point out, and I'll show it to you on the next graph as well. So most of the rural states that you see here elected Republicans to represent them in their states in the United States Senate, and that's including Indiana. You flipped a seat to a Republican who's now just starting out new in his role as your senator from the state of Indiana. I will encourage you to make sure that you spend time educating him, because this is a really, very particularly important time to understand the issues that you're facing. The reason why it's important is because for the first time, I was sharing with Don and some others at dinner last night that Indiana, both in the Senate and in the House, have nobody any longer in leadership in either bodies of the House. So this is a particularly interesting time for Indiana, because you had the greats like Senator Lugar, who was such an influence in terms of policy and the outcome of how decisions were made in Washington. And now you have a lot of education, a lot of work to do to reintroduce your elected representatives to the work that's being done in Washington on your behalf. So where the action was, and where I think all the attention in the election last year was basically in the House of Representatives. And you can see here, again, red equals rural. If you look at the districts that elected Republicans to the Congress, you can see the vast sea in the middle and the southern part of the country that have basically elected Republicans to represent them in the Congress. It wasn't enough, though, to overcome the influence of the urban vote. And you can see all the blue parts of the United States on this map are represented by Democrats. And that basically flipped about 40 seats in the House, which gave the Democrats a 236-seat majority versus 198 Republicans. If you look in south-central North Carolina, you'll see a kind of a gold or color there. That's still a race that's undecided. So we have one seat in North Carolina that's still undecided, but of course it won't make any difference in the totals. So I shared this slide too to, I think, illustrate why it is that we have the shutdown of the government, or as I call it, the shutdown showdown. It's because the Democrats have achieved taking over the House. Nancy Pelosi from the state of California is now the Speaker of the House. And so we have a situation, basically a showdown between Nancy Pelosi, the Speaker, and President Trump, who is in the executive office. And they're having difficulties agreeing on certain policies related to the borders on our southern side. And I will say that healthcare was a central issue, though, to this election. So despite all of the top-level things that you see being reflected in the discussions about the election last November and afterwards, underneath some of the primary motivations of the voters, as confirmed by polling, was that healthcare was a central issue in the election. 41% of voters said that healthcare was the #1 issue, pushing the economy out of the top spot after over a decade. 55% of registered voters said a healthcare reform bill should be a top priority for the next Congress, and none of the other policy issues offered as a choice got such a significant response. 60% of Americans think insurance premiums will go up, and that's not surprising, and those respondents will blame health insurance companies mostly for the increase in the prices. Then you can see the other sources of blame that the voters give. Trump administration 34% and the Obama administration 22%. But one of the key things that you probably heard talked a lot about, and you're going to start to see legislation being ginned up. In fact, there's already bills being dropped now on the issue of pre-existing conditions. This is of huge concern to Americans in terms of the thought of losing the protection against gaining insurance with a pre-existing condition. Most voters rank this as the #1 or #2 list on their priorities, according to Kaiser Family Foundation. But this government shutdown is still going on. Some 800,000 federal employees are working, are impacted. They are not working, and their paychecks going on Friday will be the second paycheck that government workers affected by the shutdown will be missing. And so here is a list of the departments that were not funded through the appropriations process in 2018 that led to the shutdown. Agriculture, Commerce, Justice, Homeland Security, Housing and Urban Development, Interior, State, Transportation, Treasury, and as I was telling some folks yesterday, the Executive Administration. That's why the President served Burger King to Clemson when they came to the White House. I don't know, they won the national championship in football, and they came and ate fast food. The cooks were all on vacation or not working in the White House as a result of the furloughed employees. So you can see here that it's a vast swath of the United States government. Many of you who travel, as I do, transportation, this is where the TSA, the gate agents that check our bags at the airports, they are not being paid, but they're required to work. So I always say a nice word to them when I'm going through security, as I did the last couple of weeks, thanking them for their service, because now it is really being a volunteer. So it's very nice of them to provide those services during this time. The government shutdown that were funded, so there was some normal processes that worked in 2018 leading up to the shutdown through appropriations. Those were defense, education, veterans affairs, energy, labor, health and human services. The legislative branch, they took care of themselves, to be sure, so they're working. So the question was asked, if we go to Washington for the Policy Institute, will Congress be in session, or will they be able to see us? And it's like, absolutely, business as usual within the Congress. So all the legislative aides and everybody will be able to meet with you when you're there in Washington in a couple of weeks. And then the Bureau of Reclamation. As a particular note, Health and Human Services, including CMS and HRSA, are operating completely normally. So if you're depending on checks from your Medicare payments, payments from Medicare, or if you have a grant with HRSA or working with them on a project, things are working business as usual. We are starting to see some problems, particularly in farming communities around the United States, with the USDA being closed. They're not processing support checks, and so you may see some slowdown in some of the payments of your bills from some of your customers at their hospitals and clinics, because if they're not getting their support checks from the federal government, then they may not have the dollars needed to pay co-insurances and deductibles. So you may ask me, and I'll ask the question first to myself, because we've talked about this a lot at the National Rural Health Association. What can split chambers, a Democratic House and a Republican Senate and a Republican executive branch, what can we do in terms of passing legislation that's good for rural? The first is, that as we've been talking, is infrastructure. There is a commonality. If you take Venn diagrams and draw circles, there is an overlap in interest between Republicans, in particularly President Trump and the White House, and in the House leadership, which are Democrats, and that is improving the infrastructure that seems to be failing all over the United States. There's a lot of bridges, a lot of roads, a lot of inattention to upkeep that we need to pay special attention to. So we think that there's a real chance that we could move something in the area of infrastructure. And so one of the educational things, if you're taking this to your senators, your newly elected senator and your previously elected senator, and your congressmen and women, is you need to make sure that you tell them that health infrastructure is infrastructure. So we're a little bit, we're trying to get that word to them, because when the words about infrastructure are being talked about, it's mostly in the areas that I mentioned just a second ago: transportation, education, schools, bridges, all of the things that we know of that could mean infrastructure. In this case, we want to make sure health is continued in that same frame, so that we make sure that infrastructure in our rural communities for healthcare is an important feature. The second one is, and we've been getting a lot of questions on this, and that's a new model for rural health. And we think that this is a golden opportunity for Democrats and Republicans to agree on the importance of rural health care, and everyone wants to see us thrive. You know, I showed you that map of the Republicans in the rural areas being elected, and then also in the Senate, from both the House and the Senate. It's no coincidence that there's a lot of attention now in terms of rural funding and making sure that resources are being dedicated to the work that you all do here in this room. So as we move forward this year, this will be, new models will be one of our top priorities, and I'm spending a lot of time on that myself. And on that, our innovation plan that we've been working to promote with Congress on your behalf is a three-pronged approach to innovation. We think that innovation in rural communities is centered on three things. It can't be one or the other. It's like a three-legged stool. First of all is payment innovation. And we need to make models for rural communities that make sense on alignment of payments, so that we're not depending completely on Medicare to support the facilities in our rural communities in terms of volume. So two models that are being talked about famously is the global budget model, which is in Pennsylvania and in Maryland. And in Maryland, it's actually called the total cost of care model. That will actually begin in January of 2020. So global budgets do another thing. It aligns payments across all payers. So you don't have just Medicare picking up the tab for rural infrastructure. You've got Medicaid and commercial payers as well. And so in Pennsylvania, Dr. Lauren Hughes, the State Department of Health deputy, is looking at implementing this. They started their program January 1st. They had 6 hospitals sign up, and they are beginning to implement. We're hoping that there's a lot of learning that comes out of that, so that that can be replicated very quickly and easily around the United States. And I've had a lot of interest in conversation from folks in Pennsylvania about this being something that we can try maybe in this state. The new provider type is a way into small and particularly really frontier communities in terms of meeting healthcare needs of their communities. We call it, at the National Rural Health Association, the community outpatient hospital. Others call it primary care hospitals. I've seen other acronyms like REACH, the Rural Essential Access Community Hospital. These are all models that basically put a facility that's between FQHC and an RHC and a critical access hospital or rural community hospital. So this is kind of the midway or the bridge between those two. And then the last is, it doesn't make any sense to invest in the first two without an investment in infrastructure. We have a lot of aging rural hospitals, clinics in our communities all over the United States, many of them Hill-Burton funded, and they are in need of modernization. So the modernization needs to occur around infrastructure, and our facilities need to mirror basically the ways in which we're doing the business that our communities need in terms of healthcare delivery. So in my hospital in Mississippi, for example, historically it was licensed for 66 beds. We were a critical access hospital only operating 25, but we were spread out over an entire city block. Well, the inefficiencies in that facility design was huge, and so we needed a way to maybe rationalize the delivery of healthcare services through a more modern facility designed to reflect the needs of the community. So I'll close the policy section with just kind of a horizon, something to look for. When I lived on the farm in Kansas, we would always we didn't have radars and the Weather Channel on our phones like we do now. You know how you would always see the storm clouds in the northwest, and you would begin to see possibly the blue develop in the summer, and there would be a huge storm coming in. I'm here today to tell you that I'm seeing a storm coming in over the next couple of years, and I want you to be aware of it because we have to be quick on our feet in regards to the response. So this year, in fiscal year 2018, which closed September 30th of last year, our federal deficit in 1 year was $779 billion. That was an increase of $113 billion over fiscal year 2017, and our deficit this year, according to all experts, are on track to top $1 trillion in just one fiscal year. That'll be FY 2019, the year we're in. I tell you this because we need to be watchful of discussions on methods to reduce this burden, which is significant. As Americans, I think we all share in the concern over this particularly intractable issue. But like watching the storm clouds on the horizon, we need to be prepared that rural is not basically the funding source for a lot of these reductions. So my favorite phrase is, in terms of advocacy, is if you're not at the table, then you're on the menu. And I think that when it comes to advocacy, that's my main message here today, is as we look at the intractable budget deficits coming down the road, and as politicians start to talk about ways to correct that, we need to make sure that all of our programs and services that we've worked so hard for over the last several decades are not just put onto the chopping block of deficit reduction. I put at the source here, just released about a month ago, was the Congressional Budget Office's recommendations for options for reducing the deficit. And I'm not going to go through this entire list, but I think it's helpful to maybe take a look at many of these that are Medicare related, and they directly impact, directly or indirectly, the operations of hospitals and clinics all over the United States. And so you're going to be seeing more and more discussions like this. And we need to make sure that we are at the table when these discussions are being held, so that we're not the prime folks that are being cut in terms of these kinds of reductions. So, for example, increasing premiums for Part B and Part D. Many of our community members who are on Medicare are not able to afford, perhaps, and they don't get supplementals, and they may not be eligible for Medicaid. So then this is an impact. These are dollars taken out of people's pockets in terms of cost sharing. One of the things that really concerns me is the second one, option 13, limit states' taxes on healthcare providers. That's basically the DISH and UPO program. These are all programs that really disproportionately help rural providers in many different ways. But we are working on a lot of challenges, and kind of picking up where Dr. Box left off in terms of discussion, pivoting now into policy and public health, we're looking at workforce, vulnerable populations, and chronic poverty as being our three main areas of concern, the challenges that you all deal with every day. These issues combine to make delivery of healthcare services more challenging, resulting in outcomes that loom in rural areas. So, for example, and Dr. Box did an excellent job of talking about substance abuse disorder and substance use disorder that's ravaging America. Basically, the CDC just reported last year that there are 175 opioid overdose deaths per day in rural nationally. That's really a stunning statistic when you think about that. Rural death rates for the age group of 18 to 25 has quadrupled in this same time period. So we're seeing now a disproportionate impact on certain ages, and how this is really incredible in terms of trying to deal with the solutions. And I'm really excited to see a lot of the great work that's being done here in Indiana in terms of meeting the needs of this community. As Dr. Box said, and again, just brilliant on the maternity care that's disappearing in rural America. Just to put a frame on it from a national perspective, Indiana may be better off than a lot of counties around the United States. In 1985, 24% of rural counties nationally lacked OB services, and today, as 54% of rural counties are without obstetrical services. More than 200 rural maternity wards closed between 2004 and 2014. And half of all women living in rural communities live more than the recommended 30 minutes from a hospital offering maternity services. So this is a real problem, and for me in my hospital in Mississippi, when I was there in 2003, we closed our obstetrical unit. The reasons were two. One was workforce. We didn't have the needed workforce to keep my program going. The second was liability insurance costs. Those two things combined created the situation where we could not continue any longer to offer those services. And so when you look at rural areas that have higher rates of chronic conditions that make pregnancy more challenging, as Dr. Bach so capably said, you have higher rates of childbirth-related hemorrhages and higher rates of maternal and infant deaths. One of our primary work items this year is actually looking at fetal and maternity morbidity and mortality. And I'm working myself with the American College of Obstetrics and Gynecologists. We're looking at the levels of maternity care that you all are implementing here this year. And we're looking at basically version 2 that just came out. It was just published a couple of weeks ago, and it's updating it to be more friendly to family practice OBs. There was a concern in the original release of the LOMCs, the levels of maternity care, that there wasn't enough credit given to the thousands and thousands of family practice and nurse midwives that are delivering babies all over in the United States in rural communities, and how they could be basically graded on the levels of maternity care with the appropriate level given that workforce mix in many of our rural communities. Picking up on the problem of opioid misuse, the National Opinion Research Center at the University of Chicago, which is basically NORC, released for everyone's availability the opioid misuse community assessment tool. I know that Dr. Box gave some really good statistics about what's going on in Indiana. This is a national look, and you can see the nice thing, if you go to this website, as you hover over every county in this tool, it will give you some important statistics about your county, not just the state. So an example of that is if you go to Indiana, the drug overdose mortality rate, according to this data from the CDC, is 27.6 deaths per 100,000. You'll see that it's 22.5 is the average nationally. So you all are well above the national average in terms of the number of opioid or substance use disorder overdose deaths. And then you can see on the right side of the screen how it breaks down by race and ethnicity, age, educational attainment, disability status, et cetera, et cetera. So this is really useful information if you're looking at grants, and I'll talk a little bit more about that in a second, to be able to cure some of the problems within your communities. Not to pick on anybody, but just to illustrate, I think, how you can drill down to the county level. This is just a snapshot of the highest overdose death rate in the state of Indiana, which is Fayette County, where Randy White's from, and has done some great work with the treatment center that they've developed in his community. But the drug overdose mortality rate is 72.4 per 100,000 in Fayette County in the state. And then you can see it's broken down on the right side by all of the different factors, including distribution of data over different characteristics. So this is an important CDC tool that has been released, and NORC has put it into a format that's user-friendly and able for folks like yourselves to access quite easily. If you're not familiar with this document, here is a hot link in this slide deck, and the slides hopefully will be made available to you afterwards. But the government, you know, it's funny to say that the government's done something good in a sentence. I don't say that very often, so I'll say it now. They've published a very nice book called Federal Resources for Rural Communities to Help Address Substance Use Disorder and Opioid Misuse. And I'm just going to give you one snapshot of the of this in terms of the page. Every single grant and contract available within all of the agencies of the federal government, not just HHS, are listed with a hot link to the source for the notice of funding opportunity. So you can actually go through this document and you can see the billions of dollars that the federal government are spending on opioid and substance use disorder, and you can link to those programs very quickly to see if you would be eligible in your community for the monies that's available. So I think this is a really important tool for you to take home with you and be able to look at this. And I'll share with you in a second some of the specific programs designed for rural. So 15 to 20% of all Americans live in rural areas, depending on how you count. As in Indiana, heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke are the leading causes of death, and disproportionately more so in rural than it is in urban. And then basically only 1 in 4 rural adults living in rural communities practice at least 4 of the 5 health-related behaviors listed below. I'll read them because I need to remind myself of them. Not smoking, maintaining normal body weight, being active, non-drinking or moderate drinking, and sufficient sleep. So on any given day of the month, I might violate a couple of these, depending on how stressful things are. But this is really critical, though, because we have, as Dr. Bach said, a huge problem nationally. But when you drill down into the statistics in rural, and you're seeing it with a number of the dynamics, obesity and other factors, we see that rural is higher. You know, it's stunning to see smoking rates being really a lot higher in rural communities than in urban communities. It's just amazing to me to see that kind of relationship. And so we all have improvements that we can make in this area. But the CDC is partnering. I will say that in 2017, they began dissecting the data between rural and urban for the first time in their history. They've been looking at geographic basis of data analysis versus just population-based. So we're really excited to be partnering with CDC on that work. So I hope you subscribe to the Mortality and Morbidity Weekly Review, the MMWR. If you're not, I would encourage you to freely go and subscribe, because they're now starting to cut data between rural and urban. And it's very interesting. The press, the popular press from the national press, reads those, and we've been getting calls over statistical analysis that cut rural and looked at the rural cut of the data, and they want to know why. And it's really interesting and very refreshing to be able to share some of the dynamics of what Dr. Bach's talked about and then what I'm talking about here. So chronic disease is probably one of the single most important factors that's impacting the health care of many communities, and it's more disproportionate, I think, in rural than it is in urban. This is a map, and I've shared this with you before, but I think it's so important that I share it over and over again. I don't think there's enough attention we can pay to this. This is a map documenting the prevalence of Medicare patients with 6 or more chronic conditions at one time. So this is an interesting dissection, because as you look at so it's a hot spotting map. So if you look at the redder counties, the counties with more red, you can see have higher rates of patients with 6 or more chronic conditions. Look at what's happening as you move from Texas, Oklahoma, all the way through the Deep South, up through Appalachia, including here in Indiana. You'll see much higher coloration or much darker colorations of red here in this state. You can see that chronic disease will probably be the factor that may cripple our country economically going forward in the next couple of decades. If we don't get a handle on chronic disease, if we don't find better ways to treat it other than waiting for them to get acute exacerbations of their chronic conditions which require hospitalizations, if we keep in that cyclical pattern of treating chronic disease, we are going to basically go bankrupt as a country trying to keep up with the demand of chronic disease in this country. And I think that this is an incredible challenge for us in rural, because we need to take advantage of the massive amount of work that the federal government has done in terms of expanding the availability of funds for chronic disease management. So you've got codes now that you can use for chronic care management in your clinics. You have the ability to do transitions of care across the continuum. And there are other programs that I would encourage you, if you're not using them, to look at starting those to be able to address the needs of your rural communities. I like the global budget, by the way, because it does incentivize that fact. I see a hand up.
Yeah, in terms of chronic conditions, I'm assuming you're speaking about diabetes and high blood pressure in terms of cardiovascular risk.
The whole list.
We know two of the major ways to help treat that is exercise and eating healthy, especially in rural communities. How are we getting access to changing the way people think about their diet? And especially that we live in an economy that is computer-based and people sitting at work all day, coming home and going to sleep. So how do we address those challenges?
It's a great question. So the question was, in case you didn't hear it, exercise and other healthy related behaviors that I shared on the previous screen will have a huge impact on reducing the acute exacerbations of these chronic conditions, or at least control them such that they don't progress to be worse. I think that, again, it goes back to communities coming together in a collaborative approach to look at a holistic way of addressing the chronic disease burden that we have in this country. So it can't be just hospitals, it can't just be clinics. It has to be a community-based approach using hopefully a community health needs assessment that assesses your inventory of assets that you have in your community to be able to address those problems. And so it may be starting community health workers that look at diet, nutrition, and exercise. And you start using those community health workers in a primary center, a patient-centered medical home that begins to coordinate care across the continuum to create the outcome that you're talking about. And that's the only way it will be done. And I think that there's a lot of really neat innovation that I've seen around that. So two things, the accountable care organizations, if you're participating in a Medicare shared savings program, you're incentivized to do what you're talking about to achieve savings at the top level. The second area is, and that's why I like the global budget, is because it directly incentivizes providers to be on the side that you are in terms of addressing it holistically and completely, not just medically, which oftentimes happens. Great question, and it's nice to be able to talk about a little bit about how we can solve some of those problems. So when you're talking about chronic disease and you're talking about the ability to go out and do what this gentleman just said, we're working in a milieu of poverty that uniquely does impact rural communities nationwide. And so if you look at the data, if you don't learn anything from me today, the phrase that I use all the time is health equates to wealth. If you want me to tell you whether your community is healthy or not, I will look at your county or your region's economic status of income as compared to the national average. And that will tell me more about the health status of that population than any other single factor, besides possibly education. But I think those two are linked directly. So there's a commonality there. So why is that? In 1980, 70% of rural Americans living in poverty were working. Today, less than half of the rural poor are working. So we're seeing now that the employment opportunities for those in rural areas are declining because of the declining infrastructure economically. And if we look at the social determinants of health, and we look at the contributions of what's the most important factors that contribute to the health status of a population, it's health behaviors and economic development. Those are the two largest single buckets. Next is clinical care, which we spend a lot of our time in here, and then fourth is environment. And I think those are the things that we need to be looking at and moving upstream to be able to cure a lot of the problems of this issue of poverty in our rural areas. One of the issues of poverty that I think that's important, and it's really relevant given the discussion about USDA being closed down, basically if the shutdown continues on into March, and hopefully that's not going to happen, if it does go beyond February and into March, there will be cessation of the delivery of supplemental nutrition assistance program dollars. And the reason why I show this map, because one, it's a reflection of poverty, and number two, if you look at the map, look at the rural areas of the United States. Again, I'm correlating this with the map on the legislature, the Congress representative, and now I'm looking at where you see the most numbers of food stamp assistance that's being delivered to Americans across the United States. And if you look at Indiana, you have some hot spots in Indiana of counties that have a high proportion of those that are receiving supplemental nutrition assistance. But food insecurity is a huge problem already in this country, but if we start to see the slowdown of food stamps going into the second quarter of next year, then we will have a large problem. So, what if there are no jobs in rural areas? You know, they were looking at earlier basically doing more nutrition, doing more needs assessment, or assessing the population for certain characteristics before they qualify for food stamps. And work requirements was one of them. And so this was kind of an odd situation for us at the National Rural Health Association, because we know that if you're not working, that's when you need more of your nutritional assistance. And if you don't work, that's when you need it the most, but that's when you would be disqualified from getting the assistance. So it's kind of a vicious circle. But fortunately, the farm bill that just passed worked all that out. I think it was a pretty good compromise that was achieved as part of the farm bill that just passed late last year. And then the last issue of outcomes that I think a lot of the issues that we face in terms of challenges on workforce, poverty, and chronic and vulnerable populations is hospital closures in rural America. The number has just reached, as of 2 weeks ago, 95 have closed since 2010 across the United States. Basically, it produces the lack of access to care that is close to home. And equally as important, I stress the loss of economic engine to fuel the rural economy. Most hospitals and their related healthcare structures contribute over 20% to the rural economy in terms of economic value. And it is now, and I will say that going forward, for most of us in rural communities, the hospital has become the employer for the primary care in that community. So if you close the hospital, you can say, well, we don't need the hospital, we can go 15 miles, 20, 30 miles down the road. But the problem is that if it ends the employment relationship with all of your primary care workforce, then they're going to be leaving because they're not going to be willing to open up their own office and do the billing and the collections and all of the things that are so difficult to do in this day and age. And so I always stress that that basically rural health care is like Arctic tundra. Once you step on it, it's gone, and it's not coming back. And I think that this is the message that we've been sending about this. And right now, 44% of open rural hospitals are losing money, according to Chartis. The reason for the closures are many, but obviously workforce, vulnerable populations, and poverty are three huge issues. In addition to that are reimbursement, low volume, and insurance coverage for patients that are in these communities. And if they do have insurance, it's usually a high deductible plan with basically no insurance for many of these folks, because a $5,000 deductible for a surgery is impossible for someone who's making minimum wage. So then the hospital usually ends up footing the bill for that patient or for the services that they require. Here's a map of the distribution of the closures around the United States. And you can see that they're mostly in the South and the Southeast. Here's a map, the current map of the Medicaid expansions, which has been a huge policy discussion around the United States. We just added Nebraska, Idaho, and Utah. So those three states just added Medicaid expansion per the Affordable Care Act. I know we have a new governor just elected in Kansas, and she has promised as one of her primary objectives in this legislative session is to expand Medicaid in the state of Kansas. So hopefully that will be an outcome in my state that would be very welcome, at least from my point of view. So in the very few minutes that I have left, we need an investment in rural health care. So rural hospitals, rural health clinics, and federally qualified health centers. Incidentally, Senator Lamar Alexander, chairman of the Health, Education, Labor, and Pensions Committee of the Senate, is marking up the reauthorization for federally qualified health centers. And so you need to be involved in that if you're interested in QHCs and how that is going to be working through Congress. That has to be done by September 30th, by the way, so fortunately they're a little ahead of the curve on that. In the area of rural health clinics, there are 4,400 of them nationwide. And basically they were started in 1978 to address the issues of workforce and access to care in rural communities. And so we definitely are involved in advocating on behalf of rural health clinics. One of our primary planks in our rural health clinic advocacy is raising the cap on the upper payment limit to $110 per visit. Right now it's a little over $83, close to $84 a visit, which is way below the cost of operating a clinic in a rural community. And this has been an insult really to freestanding RHCs all over the United States, especially when you look at the fact that all rural health clinics together spend less than or about 1% of all Medicare spending. So this is not a big program, but yet it serves 4,400 clinics nationwide in rural communities all over the United States. The rural safety net's under pressure. We've had a lot of victories over the last couple of, over this last year for safety net funding, opioid prevention, and some extra funding for National Institutes of Health. Here's just some of the items that were in the HHS, labor HHS spending bill that passed just before September 30th of last year. We increased some of the flex dollars that are coming to all the states. State offices of rural health got an increase in their grant program. We've had expansion of telehealth, and then in the area of workforce, AHEX got an additional $2 million for their work, and then $15 million will be available through September 30th of 2021 to support the Rural Residency Development Program. This is an important feature to adding workforce training in rural communities all over the United States. So we're looking forward to Dr. Luis Padilla at the Bureau of Healthcare Workforce, who's going to be managing the implementation of this $15 million and trying to use it wisely so that we can get more training of physicians in rural communities. Here's the list I was telling you about of all of the opioid and substance use disorder funding that was passed in the labor HHS spending bill. I'm not going to go over all of those. There's a huge list there. There's lots of money, let me tell you. If you go to that document I showed you before, it chronicles a lot of those dollars that are available and the links to that. I will tell you, and Dr. Box mentioned it this morning, but the loan period, the National Health Service Corps Loan Repayment Program, the cycle is now open for applications, and this includes the Substance Use Disorder Program, the expansion of the National Health Service Corps to cover professionals that are going to be studying and working in areas that are health professional shortage areas in terms of substance use disorder. So if you know somebody in your community that needs some assistance in terms of educational dollars on a loan repayment, and they were willing to spend 2 years in a rural community afterwards, they need to apply for this, and the funding opportunity is open until February 21st. 340B, I'm not going to say anything except that's important. The federal courts basically blocked the cuts to the 340B drug discount payment program on the outpatient side. I know that for many PPS hospitals that don't have sole community hospital protection, this has been a huge impact to their budgets in terms of a negative. And unfortunately, because of the court case, there's no immediate impact on PPS. The problem is because it's intractable to the OPPS, the Outpatient Payment System program, because what they did is the savings they got out of the reductions in the payments to rural hospitals, or to all hospitals, they just basically increased the payment rates under the OPPS system. So you can't, it's not like just turning a faucet and turning off one funding and reverting it back. They're going to have to plan this going forward. And so we'll see how that rolls out. The Democrats, as I mentioned earlier, took over the House Energy and Commerce Committee, and they've lowered the 340B scare a good bit. So we're really happy on the Energy and Commerce side that basically this will probably be put to the back shelf on at least House efforts to change the 340B program. However, the new chair of the Senate Finance Committee, Senator Chuck Grassley of Iowa, indicated that 340B will be a priority of his for investigation going forward into this new Congress. So we're going to be ever vigilant. We're going to be watching very closely Senator Grassley and the work that he does. Even if he does come out with any changes that are negative, they probably won't get through the House. So that'll be an area where divided government may be helpful. So is to stop bad legislation, at least from our point of view. So we want to encourage everyone to document the value of 340B to your facility and share it with our advocacy team and the members of Congress, because they need to know how important that program is to you and your communities. Here's some regulatory wins that we've had over the last year or two with CMS. I'm not going to go over all of those because they're basically fixed or done. We have a list of regulatory asks that are here, mostly for hospitals and clinics, and you can see this that we think are important to be included in terms of our work with CMS. We have 2 new grant programs that are available for rural hospitals, the Vulnerable Rural Hospital Assistance Program, and then the USDA Rural Hospital Assistance Program. And so if anybody's interested in some of those, let me know afterwards, and I'll be glad to try to explain a little bit more about those programs and how they might help your situations. So in the 20 seconds I have left, I want to thank you for your attention today. Thank you for your work in your communities on behalf of rural health. We have a lot of challenges. I just heard, got a call from an AP reporter that we're now seeing the resurgence of hookworm in Alabama, which is a relationship to poverty and the lack of public health resources that are being spent in rural communities, and these are largely in rural areas. So this is a tragedy that's going on in terms of defunding of a lot of the public health and infrastructure that we need in this country. And this is just going to continue to worsen if we don't pay attention to this. So I appreciate your attention to health equity, making sure that rural hospitals and rural clinics and everybody in rural areas provide access to care, that hospitals and the clinics that serve them are economic engines for their communities. And most importantly, the work you're doing on social determinants of health will pay off huge dividends in the health status of your populations going forward. So with that, thank you, and thank you, Don, for the invitation. And I'll be around a little bit this morning, so if there's any questions, I'll be happy to answer those. Thank you, Don.
Thanks, Brock. Your attention and relationship with the members of the Indiana Rural Health Association is invaluable and greatly appreciated. Like Brock said, he'll be here for a while if you have questions of him. We'll remind you that all the slides will be on the IndianaRuralHealth.org website for your use.